So thank you, Susan, and thank you to the organizing committee for inviting me today. They've done a fabulous job. It's an amazing turnout, really, on a Saturday. So what I'm going to talk about is something, I guess, a little bit different than you've heard so far. I'm going to talk about two things. I'm going to talk about psychological aspects of coping with and adjustment to scleroderma, what we do know about that. And then I'm going to talk a little bit about our day program in London. So when I first started working in the area of scleroderma, it was probably about 10 years ago now, there was almost no research, psychological research, looking at the psychological experiences and challenges that people have when they have scleroderma. And you know, you can see the list on my slide here of all of the different things. These are the main factors that people have looked at now, and each one of these now has some research behind it, and we have a little bit better understanding of the kinds of experiences that people have. So I'm going to talk about most of these in my talk. It's going to be a quick overview of the research and the information that we have. So depression is sort of the common cold of psychological problems, and in the general population, the incidence of depression is about 6%. In people that have rheumatic diseases, as you might expect, it's a bit higher. In scleroderma, according to some studies, it's about 40%. Now, the problem with that statistic, of course, is that it depends how you define depression and what you use as a cutoff. Most studies have used questionnaires that have cutoffs after a certain level, and often include people that have mild depression. There's one French study that actually interviewed people and used diagnostic criteria to look at major depression, and the percentage of people that have scleroderma that have major depression, as far as we know now, is about 20%. So that's still pretty high. That's still a lot more than the general population. So people with scleroderma are at higher risk for depression. And even those people who have mild depression still struggle. So depression isn't sort of a black and white thing, it's a continuum. So you might expect that how depressed a person is related to how severe their disease is. So that's kind of a common sense notion, but it isn't quite that simple. So in fact, depression is not strongly associated with disease measures that we've looked at so far. So things like skin score, internal organ involvement, digital ulceration, the number of objectively measured symptoms or the severity of disease doesn't seem to be related when it's assessed by a rheumatologist or health professional to depression. Now you might wonder why that is. You think that if somebody's a lot worse off physically, they would be more vulnerable to depression. But if you think about it, it's not just what the person is confronting, the challenges, the emotional and physical challenges that they're confronting that might lead to depression. It's also their coping capacity and their ability to cope that will determine whether or not they get depressed. And I think that's important. So here's a study that looked at all of these factors, and this was done by Wim van Lankveld in the Netherlands. And these are correlations between physician-assessed disease severity and depressed mood. And you can see none of these are statistically significant. So that goes to my point. Now, when they asked patients to rate their disease severity, or their symptom severity rather, and they also looked at other factors like the relationship between depression and social support, something called disease cognition, so how you think about yourself, your situation, and your future in terms of how helpless you feel, for example, and how you cope with your illness, all of these factors were at least moderately, sometimes fairly strongly related to depressed mood. And even when they partialed out the effect of disease symptoms that patients were reporting, all of these other factors, social support, disease cognition, and coping, independently were related to depression. So just to go through it a little bit, people that were married were less vulnerable to depression. People that had more support were less vulnerable. People that tended to have thoughts that were related to feeling helpless and hopeless about their situation, and people that had sort of poor acceptance of the fact that they had a chronic disease were more likely to get depressed. And also people that were active copers, that were actively trying to do something to self-manage their illness, had less of association between their coping and depressed mood. And also people that were able to express their emotions, and particularly what they've looked at is things like whether people write down how they feel, whether they keep journals, those kinds of things seem to be associated with less depressed mood. So I guess that's goes back to that common sense idea. If you get your emotions out, maybe that's a good thing for people and helps them keep healthy. So patients' beliefs and their emotional responses to their situation are really most strongly related to the meaning that they give their situation. And this isn't just true for scleroderma, it's true for all of us. So when we have a chronic disease, it isn't the disease itself that causes us to get depressed. It's what we tell ourselves about the disease. It's what the disease means to us in terms of the impact that it has on ourselves, our situation, and our future. And I think that, more than anything else, explains why disease severity doesn't strongly correlate with depression. So when we think about treating people that have depression, we need to take these things into consideration. We need to look at the kinds of thought patterns and feelings of hopelessness, for example, that people have, and help them address those. The second bullet on this slide is a study that was done by Vanessa Malkaran in California. And she actually looked at this kind of relationship in terms of what factors might mediate it. And she looked at all of these variables: disease severity, disability, pain, and then psychosocial adjustment. So a common sense approach might think that it's, again, that idea that disease severity causes depression. But if you look at this, when they looked at the correlation between disease severity and psychosocial adjustment, actually it wasn't significant. But what they found was it was mediated by disability and pain. So what that means, I guess in more simple terms, is that if you have high disease severity, it isn't that disease severity alone, but it's more how disabled you are as a result of that disease severity, or how much pain you have as a result of your disease that causes difficulties in psychosocial adjustment rather than the disease severity per se. So one idea that can come out of that kind of study that's practical and can help people with scleroderma is that maybe if we can help reduce depression, we can help reduce people's sense of helplessness and increase their sense of self-efficacy, we can help reduce their chances of getting depressed, and we can help them cope more generally and adjust better to their situation. And self-efficacy, of all the psychological variables that have been studied in rheumatology, self-efficacy is the one that seems to come out in these studies as important over and over and over again. So what self-efficacy means is it's the opposite of helplessness. It means when you feel like there's something you can do that will make a difference in your life, that will make you feel like you have some control over what happens to you. So psychological interventions need to be able to do that, to help people have that kind of feeling. And we know that when you improve self-efficacy, it also helps people manage their pain better. Okay, so that's depression. So there's things we can do about depression, even though there's a higher incidence of depression among people that have scleroderma. So what do we know about anxiety? Well, we don't know a whole lot about anxiety, so it's one of these things that hasn't been studied very much. The few studies that have small sample sizes tell us that anxiety tends to be associated with a number of different things, not just one thing. So one of the things that it's associated with is fear of death. And that's obviously something that somebody's going to be concerned about when they have severe symptoms, and they seem to be on a downward trajectory at that particular point in their disease. It's also associated with unpredictability. So that's true in general. When we are in situations that are unpredictable and uncontrollable, it makes us anxious. And part of what happens in scleroderma, inherent in the disease, is unpredictability. So that by itself is a stressor for people. Loss of function. So if you can't do the things that you do that make you feel good and make you feel like you want to get out of bed in the morning, that makes you feel more anxious. Inability to work also fits into that same category. So if you can't work, for most people, work is an important factor in terms of feeling good about themselves and their self-esteem. And then the last one is dependency on other people. Most people, there are probably some exceptions, but most people don't want to be dependent on others. And it has a huge effect on their self-esteem when they feel like they need other people to help them do things. So these are the kinds of things that tend to be associated with anxiety. And the more we can address these, the more we can address anxiety. But again, it's also the idea that I mentioned before with depression, that it's how you think about things, how you interpret what's happening to you, and your sense of self-efficacy that makes a difference in terms of whether you actually become significantly anxious or not. Okay, another area that's kind of unexplored, or has been unexplored, is sexuality in scleroderma. So like Dr. Pope was talking about this morning, pruritus and pain, they were for many years kind of ignored, I think, and people didn't pay attention to them, even though patients knew a lot about the problems that they were having with them. Sexuality is another one of those things that people don't talk about. They don't talk about it in any rheumatic disease as a whole lot. So it's one of the things that in our programs, I'll be talking about later, we thought was important to address. And we've just completed a study. I've been involved in a study with a group in Montreal, and one of the graduate students there, Brooke Levis, has just completed this study, and we've submitted it for publication. And this is based on the CSRG database. So what we found in this study was that more than half of women with scleroderma reported sexual impairment. So this is quite significant. And the problems that they described were, in terms of physical problems, were vaginal dryness, painful intercourse, vaginal pain, and fewer or less orgasms. And it was also associated with older age, sexual impairment. That's true in the general population, but also true in people that have scleroderma. It was associated with higher skin scores and more severe breathing problems, so more physical impairment. So lots of women have problems, and oftentimes they feel like those problems aren't addressed. Men's problems were more specific. They were more about erectile dysfunction, and 81% of men experienced erectile dysfunction. So this is an area that requires more research and that we're going to be looking at in more detail. And in our program, we've tried to address some of these issues and take at least a beginning stab at helping people in this area. So the bottom line in terms of psychological factors that affect people with scleroderma is that psychological health services are probably an unmet need. Probably there's, well, I know for sure there aren't many psychologists that know anything about scleroderma, and there are very few psychological services that are available to people that have this disorder. Even though in the surveys that have been done, and I've cited one of the better ones here, there's a high percentage of people that say that for them it's a high need. Okay, so let me turn to talking about our program in London. So to put this in context, as was I think mentioned in my introduction, we actually have 5 different programs, rheumatology programs in London, where people come into our facility for either 2 weeks or 4 weeks. And they come every day from 9 until 4 in the afternoon, and we take a multidisciplinary approach. The scleroderma program is the last one that we developed, and I think we've been probably going now for about 4 or 5 years with this program, so it's relatively new. And it's a pretty comprehensive team. We're lucky that we have funding to provide the services from all of these different health professionals. And I think from my perspective, it's particularly important that health professionals work as a team, and they work together and talk about the same patients together, so everybody's kind of on the same page. I think that's something that's not done often enough. So that was a key factor that we wanted to promote when we designed these kinds of programs. So the scleroderma program is a 2-week day program, and as I said, people attend from 9 until 4. And we also have, after people have finished the program, every year we have what we call refresher days, which really are sort of day-long sessions where they can come and learn about what's new in rheumatic diseases. We also have an internet clinic. Now, the internet clinic is currently down because the psychologist that runs this is on maternity leave, but it's another aspect of our program that we've tried to put into place to help follow up people, to help them continue using the skills that they learn in our program over the long term. So basically, when people complete our program, they get a password and a login, and they can log in and they can ask us questions. They can, and when people ask a question and we answer it, we post it on a bulletin board so everybody can see the answer without the person's name, of course. And so we can share information in that way. We also have a chat room where patients can talk to each other. So in our programs, people go through together in groups of 12, and they get to know each other pretty well, and often they want to stay connected after the program and support each other, so this allows them to do that. It took me a lot of talking to get the hospital IT people to allow us to do this, because there are all kinds of confidentiality issues, and what if somebody was an axe murderer or something when they were on the chat room, and it was an interesting process to get them to come around to that, but eventually we persisted and we managed to do that. So that's another thing that we've put into place. And the people that come into our program are always an interesting mix of people that have been diagnosed for a long time and people that have been only very recently diagnosed. And I know there's some people from our program that are in this room. I've seen at least 4 of them and talked to them today. So if you want a patient's perspective on our program, you can talk to them. So I thought I'd go through just for your interest, I thought I'd go through the contents of our program to give you a sense of what the program involves. So when you enter our program, you get what we call our handbook. So it's about 1 inch thick, and it contains all of the PowerPoint presentations and the homework and the additional information that people are given in our program. And we've tried to do that so people don't have to do too much writing, right? So all the information's there, so if you have problems with your hands, you don't have to be doing that. And it's something you can take home after the program and refer back to. And I know that people often do that. So the sessions that we have are listed here in bold. So there's one session that Dr. Pope does where she talks about the disease process, diagnosis of scleroderma, how that's done, what the treatments are, and the research that's ongoing, because often people that come into our program haven't had that basic information like all of you have had this morning. And then we have a session that we call Living with Scleroderma, which is an introduction to our program and an overview of our philosophy and our approach that people can expect during the program. And then we have a session on stress and illness and dealing with the stressors related to having a chronic disease. As was mentioned by Janet this morning, we also have relaxation training sessions. So relaxation techniques are a way of coping with the physiological aspects of stress and anxiety. And then we have a program or a session that we call dealing with chronic illness and emotions. And we focus a lot in that session about the idea of grieving. Now, mostly when people hear about that, they kind of wonder what the heck we're talking about. Now, grieving, most people think is something that people talk about when somebody close to them dies. But in reality, grieving is what people do related to any kind of loss. And when you think about a chronic disease like scleroderma, people have a lot of losses. They have losses in terms of what they can do physically. They have losses in terms of their futures and what they expected their futures to be like. They have losses in terms of their self-image. They have losses in terms of what they can do in their relationships. For example, their role as a mother, and many other losses, work-related losses. So I think it's an important thing for people to understand that many of the feelings that they have are related to those feelings of grieving and loss. So they go through some of the same experiences that Elizabeth Kubler-Ross described years ago about grieving and loss, where you have a stage of depression and a stage of coming to terms with it, and all of those things that people go through. I don't think people go through neat little stages, but I think that people often have a lot of challenging emotions in response to the losses that they have. And I think in terms of overall adjustment to scleroderma, I think how people deal with those losses and how they manage them is maybe one of the most important things. But you don't see anything about that in the research literature. So another approach that we take to helping people cope with scleroderma is what we call cognitive therapy. So whereas relaxation training was kind of a bottom-up strategy where you help people learn how to manage their body's reaction to stress and anxiety, cognitive therapy comes at it from the opposite end. And cognitive therapy was originally developed as a treatment for depression back in the early 70s. It's really proliferated, probably because it's evidence-based. And it's used for all kinds of things, including helping people learn to cope with chronic diseases. And the basic idea behind cognitive therapy is that it isn't what happens to us as we go through our lives that causes our emotions. It's how we think about what happens to us, the kinds of messages we give ourselves about what happens to us. So, for example, if somebody has scleroderma and their thoughts are often related to feeling like, you know, they're going crazy, or they're going to get worse and worse till they go crazy, or they have no control, or other kinds of thoughts that are exaggerated negative thoughts, not realistic negative thoughts, but exaggerated negative thoughts, which they're more vulnerable to, then it's important for them to learn how to challenge those thoughts, because you have enough on your plate to deal with. You don't need to have other thoughts that are going to make you even more depressed and more down, and ones that are actually unrealistic and cause you to shoot yourself in the foot. So that's something that people do when they're depressed, but it's also something that people often do when they're challenged by a chronic illness. So we teach people how to use what we call thought records, and thought records are basically, and I'll show you some examples of this, a way of sort of examining the way you're thinking about things and looking for what we call distorted or exaggerated thoughts. Anyway, so another thing that we do is we talk about chronic pain. We talk about the physiology of pain and the psychology of pain, now that we've recognized how important that is. And then we have some sessions that we call relapse prevention, which is kind of a fancy term to really describe the idea that people, after they've been through our program, have to be equipped to carry on using those skills after the program. If we just had them in the program for 2 weeks and they did the stuff in the program for 2 weeks and they went home and they never did it again, the program wouldn't be of much value to them. So we know that unless we prepare people for that and we actually help them plan to integrate the things that they've learned into their day-to-day lives, if they don't do that, it won't happen. If they do that planning, it's likely that they'll continue to do that, and the more detailed the plan, the more likely it is that they'll follow through, and the things that they've learned will be helpful to them. We have another session on scleroderma and self-esteem. That fits with what I was already telling you about depression. And as I mentioned, one about scleroderma and sexuality. We have one with our nurse practitioner about skin and scleroderma, and it's and our occupational therapist. And it's a lot of what Janet was talking about. And we also have with our occupational therapists what we call pacing and energy conservation sessions. So because fatigue is an important element of scleroderma, we teach people how to pace their activities. And this is important for most people that have scleroderma. It's probably even more important if you have arteriopulmonary hypertension and you're struggling with shortness of breath. And then we have, this might seem really bizarre, but we have 2 sessions on foot care. And the reason that we have this is because lots of people have problems with their feet. And if you kind of reflect on that, your feet are actually important for everything else, because if you, there's somebody in the audience that's nodding about this, who knows about this, and if your feet aren't working properly, if you can't use your feet well, that affects your mobility. And your mobility affects absolutely everything in your life. So that's why we have these 2 classes about foot care. And we try and look at not just taking care of the problems that you have with scleroderma, but also doing some preventative strategies to try and reduce future problems. And then we have a session on joint protection, because oftentimes people with scleroderma have some joint problems. A couple of sessions of that. A face class, largely based on Janet's work that she already described. Some information about community resources, both in the London and outside London. And a session on body mechanics, so simple things like how to lift things properly and sit properly if you're sitting at a computer for prolonged periods of time, trying to take into account the needs of people that have scleroderma. There's a session with the physiotherapist about joint pathology and the role of physiotherapy and the physical management of inflammatory arthritis, community resources again, and some stuff about back care, because oftentimes people have problems with their backs. And then we have a whole load of sessions with a pharmacist. So each of these sessions is about an hour or 50 minutes long, and that's because there's so many different medications that are involved. You've already heard about those this morning. There's so many medications that are involved. It takes quite a while for people to kind of figure out what the heck's going on with all these medications. They're complicated, right? And this is much more complicated than rheumatoid arthritis or even lupus. People are on tons of different medications for different problems, and even one problem can have many different medications that could be used for it. So to figure out what these are, how to use them, what the side effects are, and what to watch out for, takes people a long time to sort of get a handle on and feel confident. So that's why we have all of those. We also have every day people are in physiotherapy doing exercises, and we have we're lucky we have a 94-degree hydrotherapy pool down in the basement of our building, and people like that. It makes them feel good. And so this just sort of highlights another aspect of our program. So we're trying to help people stay as healthy as they can and do whatever exercises they can and stay as active as they can, taking into account their scleroderma and their limitations. And the last bullet here is just to indicate our family group sessions. So for both the scleroderma program and all of our programs, on the Friday afternoons, the 2 Friday afternoons of the program, family members and friends, significant others come and they learn about scleroderma and they learn about our program and what the person who is in the program is learning, so that they can support that and those changes better when the person leaves the program. We think that's really important, because if somebody goes home and their spouse or their significant other or the people that are important to them don't understand their disease or don't understand what they're trying to do after the program and the lifestyle changes that they're trying to make, they won't be able to support those things as well. So each of the things that we've included in the program we've put a lot of thought into, and each one of them has its place and has its reason. This is an example of our schedule for our program. This is actually last year's schedule, 2011 schedule in terms of scleroderma. Our last program was on June 20th. So because of the numbers of people with scleroderma, we don't run that many programs. I think if we had more people come to our programs with scleroderma, we would increase the number of them. But sometimes it's hard getting even 12 people from our particular catchment area just because it's a rare disease. But I think we have some ideas about partnering with people in Hamilton to look at that. So in 2012, actually, just to give you the information, our next program will be on June 4th. So 2 weeks beginning June 4th, 2012. And just to give you an idea, if you're interested in this, what your schedule would look like. Each week that you're in the program, you get a schedule that looks exactly like this, or very close to it. So everything's kind of laid out so you know exactly what to expect every day. And one of the things we've tried to do, because you might be thinking this as I've been talking about it, is we've tried to make things so that people that are not feeling great can still manage. So we try and intersperse things that are active, like physiotherapy, with sessions that are quieter and more relaxing, like relaxation training or an educational session. and we try and give people some breaks during the day so that they can manage. One of the rooms that we have where we do our relaxation training has 6 recliner chairs. So if somebody's having a bad day, they can go into that room and they can take a little bit of a break and not feel like they're trapped and they don't have anywhere that they can go. So you can see it's a pretty busy agenda. Sometimes people think, well, I don't know if I'll be able to manage that because it's so busy. But so far, people have been able to do that with the breaks that they take. Sometimes they're tired at the end of the program, but so far nobody said it wasn't worthwhile to them. Okay, so that's the program. One of the things that we do with all of our programs is we try and evaluate them. And I only have data now so far since we've been evaluating it for about 19 people, but I'll show you some of the data that we have for that. So these are the demographics for this group, mostly women. And these are the outcome variables that we've looked at so far. And the ones that are bolded, in case you're not always looking at statistics in your life, are the ones that are statistically significant. In other words, there was a statistically significant or reliable change in that variable between the time people came into our program on average and the time that they left the program. And so the Scleroderma hack is one of the things that we looked at. Or I'm sorry, I should start with the hack disability index. And it was slightly lower for people that had finished our program. And then the Scleroderma hack scales are ones that look at specific symptoms of scleroderma. And the things that looked like they changed a bit in our program were Raynaud's symptoms, digital ulcers, and their overall score was almost significant, but probably it isn't because their GI symptoms and their lung symptoms didn't change in the 2 weeks that they were in our program. So these aren't too bad considering it's only over a 2-week period. We also looked at coping with pain because that's a significant issue for people. And what we found was that this is called the chronic pain coping inventory. So it looks at different coping strategies and the numbers of these coping strategies that people used and the ones that are helpful coping strategies and less helpful coping strategies. So the less helpful coping strategies are called illness-focused strategies, and the good coping strategies are called wellness-focused coping strategies. And there was a change in the latter, the wellness coping strategies in the people that attended our program, and improvement. We also looked at something called the Patient Health Questionnaire, which is actually a questionnaire version of the DSM diagnostic criteria for depression, for major depression, and other types of depression, dysthymic disorder, which is like a mild depression, and some anxiety disorders, panic disorder, and then lumped into another category of our other anxiety disorders. So even though we had 19 people in this sample, there's still a relatively small number of people that were having these problems significantly and met the diagnostic criteria before the program. But you can see that after the program there were fewer people that met those criteria. And also a measure of depression and a measure of helplessness, both those measures improved while people were in the program. So it looks like overall we help people emotionally while they're in the program. They felt better at the end of the program than they did at the beginning. And then we looked at something called the Illness Cognitions Questionnaire, and that goes back to what I was talking about in terms of how people talk to themselves and how that influences their mood. And so thoughts related to helplessness, acceptance of their illness, and even the perceived benefits. So perceived benefits of a chronic disease are when people think of there are actually benefits they got out of having the disease. This might seem like insane, but sometimes people can find a silver lining. So for example, one simple example might be that because they've gotten ill with their disease, it's brought them closer to their spouse, right? And that's kind of a positive side effect among all the negative side effects that they've experienced. So we looked at that. It's part of this questionnaire. So people's helplessness improved, and the perceived benefits that they were able to find seemed to improve. I don't know what exactly those benefits were. We didn't sort of document those in detail, but their ability to think about that at least improved between when they entered the program and at the end. And we, of course, also look at patient satisfaction. So not only are the statistics and the objective questionnaires important, but what the patients actually think in terms of the feedback they give us about their experience in our program. So we have a pretty detailed questionnaire that looks at every element of our program, and I don't have, it might bore you to death to go over every one of these statistics, but I can say that each of these categories never fell below 4 on the 5-point scale. So that's pretty good in terms of how satisfied people were with what they got. And then just to give a summary, you can look at the overall quality of care, the mean or average rating that we got from people, and this isn't just from 19 people, it's from everybody that's been through our program, was 4.7 out of 5. So we're pretty happy with that. It makes us feel like we're doing a pretty good job. Not that there's not room for improvement, but we're not doing too bad a job. And we always ask the question, and this is true for, again, for all of our programs, would you recommend our program to a friend or family member? And it's kind of the acid test, right? And 100% of people that were in our program said that they would, so that's good. So that was an overview of some of the psychological factors that affect people with scleroderma and a little bit of information about our program. And at this point, I'd like to answer any questions that you have. So you can go home after a very long day.